But thank you everyone for joining today. We're really excited for today's talk. Dr. Lam is a geriatrician, health services researcher, and assistant professor in the Division of Geriatrics at UCSF. His primary research and work interests are on aging in place and its converse, institutionalization. In his clinical work as a geriatrician, he regularly counsels and helps persons as they encounter health crises and are debating whether it is safe to stay at home. This flows into his research investigating the experience of disability in late life, how disability and medical conditions threaten independence, and the extent to which services and equipment make a difference. His studies use mixed methods, including longitudinal analyses of repeated measures, national studies on aging and Medicare data, semi-structured interviews, and focus groups. In his quality improvement work, he is involved in helping improve geriatric care at the San Francisco VA through transdisciplinary discharge planning and making the emergency department age-friendly. So welcome, Dr. Lam. We're excited to have you.
Thank you so much. I'm excited to present. My mentor, Ken Kavinsky, said that this is going to be a friendly audience because you guys are another Pepper Center also interested in care delivery. So hopefully this will be really interesting. And I think a lot about how, Lee has also done a lot of the work in this area, thinking about how do you make decisions at this phase of life, the final quarter of life. I initially thought I would go through some sort of long introduction, but I thought I would really just jump right into it. Today's talk, I'm going to start with a quick audience poll. I haven't tried this before, but I'm curious actually to know what people think about this space. So it'll be informative for me. And then right afterwards, I'll talk about why I'm interested in this transition into long-term care facilities as a geriatrician before going into some of my selected work, stuff that I've published and also manuscripts that I'm working on right now. And then we'll go right into Q&A. So to start off, I wanted to present to the audience a sample case. I think this should be familiar to anyone who's practiced clinical medicine, really in any field, if you care for adults or older adults. You have an 84-year-old woman with mild cognitive impairment and some chronic conditions, hypertension, osteoarthritis, and osteoporosis. And she's currently living with her spouse at home, who's a 90-year-old man, also with mild cognitive impairment. She's fallen once in the past 6 months, went to the ED just to make sure that her head was okay, went back home and things were all right. She has a history of light use of health services. So sees a clinician, primary care physician in clinic every 3 to 6 months. Family is willing to help out and is doing so, already helping out with some groceries. There's no imminent medical threat. She has adequate savings. She's ambivalent about whether or not she does things for herself or whether or not other people help her. And this is a case based off of a paper published by Dr. Kane in 2006. The question that I would ask the audience at this point, we'll see if this works, is which long-term care support and service setting would be best for this particular situation? So I've included some light details about the case again, and I'm just going to activate the poll to see whether or not it works, if people can log in. And I really hope it does work. And if it doesn't, we'll just do this as a thought exercise. But I really wanted to see if it would. There we go. So I think the poll is now active. If people want to log in, and I'm curious to see what options people pick. I've included I don't know as an option. I've included things ranging from skilled nursing facilities to assisted living, to home with paid help, to home with unpaid help, and that middle ground of adult daycare. And you can vote twice, actually. So I'm curious to see, I realize there's oftentimes some ambivalence as to what would be best. And I think this is supposed to show up live. I haven't used this before, but oh, good. So things are, so feel free to vote, and I'll give some people some time. So it seems like there's a fair amount of consensus, a lot of push for home with paid and unpaid family caregiving, but unpaid family caregiving, only people, hospice, SNF, not that kind of person. Interesting. Now, in this next slide, I want you to keep thinking about this case, only now, I'm just going to try and advance it. We'll see if it goes. Well, Okay. I want to advance my slide, but it's not advancing. My apologies. I'm running into some technical glitches.
Maybe you have to end the poll everywhere. Sure.
Yeah, I ended the poll everywhere. Let's play again from current slide. There we go. And let me switch back to share my screen if you give me a moment. Now, I want you to think about, again, the same case, only now she has fallen, she suffered a minor head laceration, and she's currently in the emergency department. Okay, same case, 84-year-old woman, history of one fall, light use, was living home with husband, family's willing to help, savings, doctor's prognosis, nothing imminent. And now she's in the emergency department for a fall. Which service now best suits this particular situation? And I think this one is live as well, so we'll see. And feel free to chime in if there's any technical glitches. I don't know whether or not. So similar with home with paid and unpaid family caregiving seems to be still a major choice, though we've got a couple more votes now for assisted living, long-term care, and again, assisted living memory care as an option. Now, I'm gonna have to refresh this and I apologize. We'll go through it quickly. Now, I want you to also think through just what motivated your recommendation. I don't think I have an answer for you guys for the time being, but I want you to just sort of reflect on what was it that made you think one way or another. And I bring all of this up because, again, this question of what would be the best service setting, long-term care service setting, is just this thing that has fascinated me throughout my residency and fellowship and my research career. Because I actually think, I'll posit that long-term care, whether we provide it in facilities or via home and community-based services, is going to be the defining problem of geriatrics for the next 10 years. And the reason why is because, I think we all talk about this aging demographic. I don't think geoscience innovations are going to be able to stop aging, at least in the next 10 years, in which case I feel like as geriatricians, what we will care for are aged persons. And when I think about what it means to be aged, can't help but think that the hardest part about aging is not being able to do what we used to be able to do. And if that's the case, I can't think of any intervention that fixes people or helps people when they can't do the things they used to be able to do other than long-term care. And I think the first response that I get when I share my interest in this as a doctor is, why am I interested in long-term care? It's not a healthcare problem. And to that I respond, well, 10% of hospitalized patients end up in a nursing home long-term. And when you look at the nursing home population, 3/4 of them were preceded by hospitalization. I actually started as a hospitalist. Canadian training for internal medicine is almost all hospital-based care. And the thing that I kept seeing was, this is the thing that we are dealing with. In addition to or beyond all of the medical issues, this is the problem. Where does this person go after we fix this acute medical problem? And maybe I'm just a sensitive person, but when I would talk to patients who are thinking about leaving the hospital, I just felt like this was the hardest thing that they were going through, more than the medical issues, which as a system, we were by and large able to route people in the right direction. And so, I look at some of the qualitative literature where you ask people what this transition is like. They describe things like, I had sicknesses, I had health issues, 2 operations on my hip. That's why I can't walk well. I had this thing with falling. They came, they took me to the hospital, and that was it. No more going home for me on my own. The social worker said, I am here now. The doctor said, I need to come here. What can I do? I have no choice. And so, I think it's hard to divorce the idea of long-term care from the health conditions that require people to need long-term care. And if people lived forever with no health conditions, I highly doubt anyone would need long-term care, but they are intrinsically related. It's not just that healthcare precedes the need for long-term care, or health crises precede the need for long-term care. The other thing that happens is that when you get long-term care wrong, it's also related to healthcare use. And so when you look at surveys of older persons entering the emergency department, 1 out of 8 visit an emergency department because they can't care for themselves at home. And once again, when you look at the qualitative literature to better understand these stories, you see these stories where caregivers are saying, everyone discouraged me from taking my father home, everybody, but I just thought I'm going to do it. And finally, I figured, well, maybe I can't. Where does a person like that end up? The emergency room. It was bad before. Now it just went downhill real fast. It was getting to be too much for me trying to do it all. And so when this was another thing that I was seeing in the hospital where I was admitting patients where there was nothing medical going on, the so-called social admission. And I remember thinking, this is so bizarre because we don't think it's an emergency in the medical realm. And yet if they're in an emergency room, someone on their side thought it was an emergency. And I've always had this mantra, just listening to patients where they are at. If this is an emergency for them, maybe there's something wrong with our medical way of thinking rather than something's wrong with their understanding of what an emergency is. And so again, once again, I just became very concerned with how our neglect of what the care environment was and how we planned around that was actually also driving up healthcare utilization. And again, an important health concern. I saw this in my personal life. This is my grandfather and my uncle. We cared for my grandfather at home with a hired paid caregiver for years. We spoon fed him. He had progressive Parkinsonism, and we spoon fed him for many years. We had a whole shift set up. There would always be a child coming by for dinner. And then on weekends, we would all gather, and I would see my grandfather basically every Sunday and help out with caregiving then. And at the age of 100, he had a stroke. And I remember thinking, wow, the medical issue here is actually quite straightforward. He was last seen well the night before. You had to admit him, do a CT scan, confirm if it's hemorrhagic or not. This was thrombectomy within 24 hours. So we knew he wouldn't be a candidate for TPA because he was last seen well more than 6 hours ago. You have to get an ECG, you have to get an echo, you have to check for blood pressure and diabetes, you have to put him on dual antiplatelet therapy. The medical stuff we could deliver. That was pretty straightforward. But the hardest question was, now that he had a stroke, where does he go? And if we got it wrong, what would be the implications for his quality of life, for his safety? What was the best way forward? And I realized that this is the problem that patients and families face, which is very, very hard. And you'd think that since we see this so often, we would be good at it. But when you look at studies then of discharge planning and the default destination for people after they leave a hospital, if they're in a state like this, it becomes quite clear that we really don't make good decisions in this space. So here's a quote from Bob Burke's research looking at the quality of SNF discharge planning after hospitalization. It was unclear who ultimately made the decision for any particular individual to go to a SNF. Most clinicians cited the patient as the ultimate decision maker, but then many noted the patient would go along with the MD's recommendation, but MDs often did not feel like the ultimate decision maker and suggested that therapists were deciding, an idea that therapists did not concur with. And so I like this meme because this is my understanding of what's happening, that basically nobody knows who's making this decision to go. And I find this, again, very puzzling. It doesn't help that in the US, and to be fair, also in Canada, there's been a rise in assisted living facilities and caring for people, that the assisted living population increasingly looks like the nursing home population. And also there are, but with the key difference being that assisted living is often paid for privately and is thus also highly related to race and socioeconomic status. But you can see here, when you're looking just at basic demographic data for the nursing home population versus the assisted living population, the prevalence of dementia or moderate severe cognitive impairment is pretty high there. And there's also significant need for bathing in the assisted living population as well. So when you think about it, just when you look very, very broadly demographically, we know most people want to stay in their home as they age, but yet most people will also develop a need for long-term supports. That is an extremely expensive part of health expenditure. It's up to 14% of national U.S. expenditure. And that for a lot of people, even though they want to stay at home, about a third will end up in a nursing home or residential care, whether they liked it or not. And so I would argue then, based on that information and my own experience, that the question of long-term care use is related to aging and health. It's related to healthcare and medicine. Whether long-term care facility use is extremely common. It's also extremely important to older persons and their families. It's very expensive. It is an issue of diversity, equity, and inclusion. But above all else, it's poorly understood with almost no evidence basis for decision-making. And it frustrates me because I think at some point I realized, I guess I'm the expert on the clinical frontier, and yet I still don't know what the evidence is for making any of these decisions. And I think this has become an increasingly hot topic as we're worried about our aging demographics. This is a think tank which did some focus groups on how the transition in, and they describe it as such. We've made a system that calls upon elders and those who care about them to flex and adapt in a crisis without preparation or resources. It's a moral failure to take the hardest part of the long-term care equation and then throw it on vulnerable patients and families who are ill-equipped to manage it and make it their problem to solve. And this is one of the things that I really emphasize. If so many people go to long-term care alongside or catalyzed by a health crisis, you're now taking a person who's going through a new change in how their body works and asking them to navigate a system which is just exceedingly complicated. And when you ask people how could this process be improved and what's the reflections on it, they say, I don't understand why there isn't more information on the internet. There's really nothing out there to help you navigate it. The only thing I would like, when you ask what information people would want, I would like to have a bit more information about what help is available at home, probably more of a discussion about the ways in which circumstances could change, how they might change for the carer whose own health or something may be deteriorating. My take, having tried to counsel people through a lot of this, is that there's so much information coming at people that people know they want more information, but it's hard for them to put a finger on exactly what that information is. So when I think about the research questions that drive me, the first one that I'm working on at this early phase of my career is basically, what do people want to know about moving into long-term care facilities? And how can we be generating that evidence? And I think from there, I hope to answer maybe the harder questions, which is like, when is the right time to move into a long-term care facility, if ever? And to what extent is long-term care also healthcare? And in other words, people, the way that I frame that question is I think a lot about how people move into these long-term care facilities ostensibly for safety. And my question is, what's the evidence that actually moving in is safer or less safe? And I think that's something that I would love to be able to study because, again, common problem, expensive problem, and a key part of geriatrics. So with that framing, I just want to present some of my selected work as I've tried to start tackling this question as a professor and still an early investigator. The first paper that I've published directly addressing a question that I think people have is just how often do people leave nursing homes and assisted living facilities? This question is motivated by the fact that I've had conversations with patients and families where they say things like, I'm keeping mom or dad's home because I don't know whether or not they're going to come back. And I think, wow, that's a very expensive decision to make, to hold on to this. And I know that this might be predicated on hopes that you have, and it might be important for not purely financial reasons, but there's a big financial decision that you're making here to keep the home just sort of unoccupied and open. Wouldn't it help to know, is it likely or not? And so here, I'll just expose some of my methods. That what I'm really trying to do is leverage national surveys to study this question. I primarily work within the National Health and Aging Trend Study, which surveys people annually before and after they go into nursing homes and assisted living facilities. And you can see here just in the data that you have people who are in the community, and then you can see the moment that they go into a nursing home. And what I've done is I've used this data set to cut out the number of people who go into nursing homes or assisted living facilities basically over the past 10 years. So there are about 12,000 people in NHATS. I get rid of the people who started in nursing homes and assisted living facilities because you don't know how long they've been there, and you have some prevalence bias. That leaves you with 10,000 people to 11,000 people who started in the community. And then you can basically find about, at least from 2011 to 2018, approximately 1,000 of them have moved in. And with that group of people, what I studied then was I followed them over time. You also know when they died. You can also follow them to see whether or not on a subsequent round did they ever report that they were living in the community. And I generated this figure, which was recently published in JAGS, examining the bottom line here. This is a survival graph. And the bottom line shows what's the incidence of people returning to community living and when. And then the top dotted lines represent death. And so this is a graph trying to answer what happens to people, like how do people leave nursing homes and assisted living facilities? And by far and away, they die. At around the 4-year mark, the mortality is about 66%, whether you go into a nursing home or an assisted living facility. And then return to community living is fairly low. It's about 7% for both groups at the 4-year mark. But you can also see the power of this graph is that it shows if you do return home, when is it likely to happen? And you can see if they do return home, it happens within the first 2 years. And so from this, I drew the conclusion that one, it's just very uncommon. If it does happen, it's within 2 years. Mortality didn't differ between the nursing home and assisted living populations. Here, I had to finesse the definition of assisted living to exclude persons who were in independent living, but I looked at that as a sensitivity analysis. And then I looked at some factors to see what's associated with returning home. Older age, dementia, previously living alone, all made it less likely that you're gonna go home. I don't think any of that's particularly surprising for people who work clinically, but it's just nice to put a flag in the sand. And I'm aware of the nuances of different long-term care arrangements, that independent living really is a different group of persons who are going into sort of apartments attached to places where services can be easily provided. And so what I did was, I think of assisted living not really as a residence, but more of a circumstance where you're being assisted. And so when you exclude that, that's when the mortality seems quite similar between assisted living versus nursing home populations. But when you include independent living persons, the mortality decreases. So you can see compared to in the overall cohort, it drops once you add them in, and that effect is more pronounced in the assisted living cohort because I'm just varying my assisted living definition. But still quite high at 4 years, even if you include independent living, there's a 50% chance that you passed away at 4 years. I'd like to think that the impact of this was the best example that I could think of the impact of this work, because I think, I wanted to publish it because, again, part of me just wanted to put this under the microscope. I mean, I assumed that few people leave once they go in, but this one respondent on Twitter said that it was helpful to examine just whether it's a myth or not a myth that when you go to a nursing home, you go there to die. And at least there's a number now that it's 7% likelihood of you leaving. So I do think I'm going to try and feed this into subsequent grants to basically point out that this is a big decision because it's rarely reversed. Whether or not it should be reversed or in the future, I think that's an open question. But I think it's an important thing to recognize that when we make suggestions or when people say the doctor said I have to come here, what choice do I have? You are really resigning people to an outcome. And I don't know whether or not that's good or bad, and I'd like to answer that, but I think this is important preliminary evidence for that process. The next question, this is the paper that I've been working on for some time now, is, okay, so we now have a rough idea when people go in, when are they likely to leave, if ever? The question that's been plaguing me for a while is, what do people look like when they go into a nursing home and assisted living facility? In other words, when does that happen? Not just in terms of age, which I think is pretty easy to find out, but what does life look like before people go in? And I need to mention at this point or expose the conceptual model that I use for my work. Whenever you work with quantitative data, you have to somehow reduce the messiness of the real world into some sort of model for what's happening. And I would say that a function of aging, or a reality of aging, is that it's more likely that you become disabled. In which case, as you get older, your ability to complete things like ADLs that you even need to do to live gets harder and harder. And so I'm using this diagram to show that as you get older, function is likely to decline. But just to live, you have to get over a fence in order to complete things to stay alive. And supports such as caregiving, but also things like equipment, essentially are trying to bolster people's ability to function so that they can complete their ADLs. And the way that I see the process of seeking institutional care is that you're making a decision. It is just but one way to get supports. And the real goal of it all is so that ADLs are completed so that people can still have dignified lives in spite of the fact that their function is impaired underneath it. So I just wanted to expose this just because I think this is the fundamental conceptual model that I use when I'm thinking about my analysis. And so here, what I'm trying to express is that I'm very interested in finding out to what extent are we providing this sort of care, like at that juncture when people decide to go for institutional care, how much is being provided by families, and how impaired or how small are people functionally in terms of their ability to do things? So once again, I'm trying to leverage this cohort. Now I've expanded it out to 2019 because I don't need as much follow-up time. I'm trying to study what's happening before people go in, but you can see where I'm trying to get some economies of scale on my research. And here I have to use slightly more complex analysis. And I display this graph just to be completely transparent with regards to what I've done. So in NHATS, in this top box, the first step is to include everybody who's gone into a nursing home or assisted living. So here, each line represents one person. The blue dots represent over time when they were interviewed. And if it's orange, it means that when they were interviewed, they said that they were living in a nursing home or an assisted living facility. They could also die. And the green box marks the people that I included. So it's anyone where they went from blue to orange. If they went into a nursing home, they told people the month that they moved. And that's that dotted red line there. And so what I'm doing is I'm finding all the people who went in. And then step two, I'm trying to line up the red dots. So time equals 0 is the month that they moved in. And from there, I can set up a time scale that isn't round based, but month based with regards to when they were interviewed relative to the time that they went in. And then what I did was I grouped people based on half-year intervals to try and get a sense of what's happening to people's function, essentially using the population averages as a proxy, or as interpreting population averages to represent what is likely to happen to people relative to the time of going in. So I illustrate this because data are essentially prospectively collected. So people don't know that they're going to go into a nursing home at the time of interview, which is particularly powerful because now we don't have recall bias. But there are obviously some nuances when you think about how I collected the data and possible sources of bias. But I think it's pretty good data because I think it's otherwise very hard to find out what happened to people before they went in. So this produces interesting longitudinal data. So when you look across months and this entire cohort, you can see at least from -4 years to +2 years, we have over 200 participant rounds supplying data for each of these 6-month intervals. You can see that essentially this is a figure on the left. It's on the y-axis is the number of participant rounds occurring. If it's in dark blue, it means that they were alive and interviewed. If it was this hollow white, it means that they were alive, but no interview occurred at that time. And you can see after people go in, the likelihood of them being deceased starts to increase, and there is a little bit of loss to follow up. I hope this figure makes sense just with regards to the quality of the data that I'm gathering. And so this is the manuscript that I'm working on now. So the first question is just how functionally impaired are people before they go into long-term care facilities, both nursing homes and assisted living facilities. And so you can see from this figure that 4 years prior, actually 6 months prior, maybe the point of interest that a lot of people like to focus on. A lot of people are actually already getting help for 2 or more ADLs and even more are reporting some difficulty and 2 or more ADLs. So it's sort of on the 40 to 60% range that people are having difficulty, and then that jumps up with more people getting help once they enter a long-term care facility afterwards. The other interesting thing about NHATs is that every single round, people are asked questions as to what sort of help they got and how many hours of help they got. And so here I was interested in also exploring how often is help being provided by unpaid persons versus paid persons. And so you can see, if you consider help for any ADL or IADL, so this is things like grocery shopping, going to doctor's appointments, almost everybody is actually getting help for up to 4 years prior to going in. For paid help, the use is quite small, but it does start to grow a little bit before people go in. And then once people go in, the likelihood of any help drops off to about 60%, and paid help drops further. And this, to me, when I look at this figure, I interpret this as a lot of people talk about how healthcare crises catalyze the transition into long-term care facilities, but they've been helping out, caregivers have been helping out for years and years. And so this is the first proof that I've at least seen that yes, in fact, that's the case, that almost everybody has somebody helping them in some way, shape, or form before they go in. And I thought this figure is particularly interesting. Here I was trying to show at a population level, what's the median and interquartile range of help being provided to people. And you can see here that 6 months prior, the median caregiving hours per week is up to 20 hours per week, with quite a wide interquartile range. At the top end, basically 25% of people are getting over 58 hours of care per week in the 6 months prior to them going in. An interesting quirk of NHATs is that you cannot, they don't count facility hours. So when you look at the care hours happening afterwards, what you're seeing is the reduction in supplemental help. So it's being borne by unpaid helpers or hired paid helpers beforehand. And then that tends to drop off both in terms of prevalence and also hours of help after people go in, with this also interesting phenomenon that I don't know if it's been reported in quant literature before, but also people know who've worked in the field that oftentimes even when you go in, you hire additional help after you go into assisted living or a nursing home sometimes to supplement the facility-based care. And so you can see here, it seems like in that transition period, if people do hire help, oftentimes the hours are quite high for that help being provided, then it tends to taper off. And then as people live longer and longer, it seems like the supplemental paid help starts to increase as well. So the conclusion from this study that I'm on, this manuscript that I'm working on right now, is that people transition into long-term care usually actually after extensive efforts were made to keep functionally limited older persons at home. That your average entrant was limited to 2 or more ADLs, got 20 hours of total care per week for a median of 19 months if they did get help. Only a third got any paid help before entry, and supplemental caregiving continues in 61% of cases after entry for a median of 10 hours of care per week. So again, just really trying to color in what this story is with regards to what long-term care entry looks like and what is normal in this situation. And I'll share here, I just started recruiting for my semi-structured interviews. Yesterday, I was just a friendly family caregiver at the long-term care facility where I'm recruiting asked me questions in the elevator, and I couldn't help but ask her, was this information useful to her, as she was talking about her story of eventually putting her husband in to the long-term care facility. And I said, I think what I'm trying to communicate with this is that for a lot of family members, they don't know if what they did was normal or not. They're looking for peer validation. They're looking to know whether or not this was okay for them to do. And at least for her, when I said, yeah, if you were giving 20 hours of care per week before this, what you did was totally normal, at least in the US. And she did say, yeah, that is relieving to hear. So again, I don't know how all this will be incorporated yet into decision aids, but I hope this is at least interesting and providing a more nuanced picture of long-term care entry than has been previously produced. Question number 3 that I'm working on also as a manuscript that I've split off into a separate paper was, as a clinician, I know that the journey into long-term care facilities is not monolithic, that there are a lot of pathways in. And I know sometimes people go in because something happens, like a stroke, and all of a sudden your hand is forced. And other times people come in because it's the fifth fall after 4 falls, and they've been struggling for years and years and years. So I'm aware that sometimes people go in because of sudden declines in function, and other times people go in because of gradual declines in function. And so I'm leveraging the data set and some novel analytic methods to look at this as well. And this is the raw data out of NHACs. If you look at number of ADLs with independence, you can plot that on the y-axis. And again, you've seen sort of how I've structured the data. Every single one of these data points is every single one of these lines or trajectories is one person. And you can see at the time of nursing home entry, there's this downward rightward trajectory of decline function. And the question is, well, this raw data is the total, what you can see at a population level tells maybe a story of collective burden prior to people going in, but the individual stories, there's all sorts of individual stories in this. And the way you can balance both of these methods, basically all of this data alongside our understanding that for individuals it might be different, is what some call group-based trajectory modeling. And so when you clean up this data, what emerges is this picture, is that you might have 3 or 4 or 5, and there's some nuance to this analytic method, but I can paint this picture that some people go in because there are sudden declines. That's sort of like your red and green trajectories, where at the time of entry, there's starker drop-offs in function. But some people go in because, again, they've been trying for years. And interestingly, another group emerges where there are people who have apparently not much ADL impairment, but they go in and they stay in. And the power of this analysis isn't necessarily in painting these trajectories, which we kind of know exist. It's quantifying how often they happen, which I think would be important when you're thinking about system planning for this. You can see here that about 60% of people are experiencing some functional decline, but now you have these other stories that emerge where for maybe a quarter of people, they're struggling and really struggling. This might be my grandfather, where we were already spoon feeding him for years. Before we eventually placed him. And then for others, and I don't really know yet what this low needs group is or how to characterize it. And the interesting thing is that once you categorize people into these groups, you can then run chi-squared analyses to figure out what correlates with these groups. And so the preliminary analysis, what I've done here is I've tried to figure out, do these groups differ based on age? Or is this related to people's gender? Or is this related to race or dementia, or whether or not you're going into a nursing home versus an assisted living facility? And so you can see here, if you focus on the left side, the high needs group, the people who struggle and really try hard at staying at home before going in, these are people who tend to be non-white or more non-white than the rest of the population. These are persons who tend to have dementia, and also they are the ones who tend to enter nursing homes. And the high needs group and the gradual decline group tend to be a little bit more similar. Whereas the sudden decline groups and the sudden decline group, less likely to go into nursing home. And the low needs group, these are the persons who may be the ones, the low needs, the brochure assisted living people are the ones who are probably in this low needs group. And so I think this, again, colors this picture because, again, I think my race, Asian people, are long characterized as people who would never put their loved ones in a nursing home. And I remember a word of advice that I got from a geri psychiatrist was that, these ideas of filial piety were born in a time when people did not live as long as they do now. And people hit breaking points, and that might differ based on your race, but this perhaps adds a bit of nuance or color to what I think are common stories that we tell in this space, that people do still go into nursing homes regardless of your race, but it might be at a different point in functional decline. Again, just trying to show me leveraging this data set to answer questions that I think people ask about what's normal for going into long-term care. This is just a question I had, which was sometimes people ask, if I send them to long-term care, well, maybe their social life will actually improve. And there are social measures in NPAT. And so this is just looking now using spline models, again, anchoring at time 0. What happens to different activity participation when people go in. You can see here that visiting with others and going out for enjoyment continues to decline, whereas attending religious services, participating in clubs actually does increase. So participation in formal activities that you might see offered in nursing homes and assisted living facilities does in fact go up for what it's worth. Again, is it good? Is it bad? I don't know. And the methods need to answer goodness or badness require a lot more work, and it's going to get very complicated. But I'm just trying to color and add evidence to this decision process. What is all this leading to? I hope to create a tool to supply evidence to support decision-making about long-term care entry. I don't know if it will change, just sort of like, ACP and advanced care planning. I don't know if it'll change people's decisions, but I hope I'm speaking or working on this information problem as it relates to people wishing they knew more about not just options, but how do you choose between options. And down the road, I hope to answer harder questions like what is the causal effect of long-term care entry on outcomes like ED utilization, falls, and mortality. Oftentimes I realize it's going to be hard to randomize people, which is my moonshot idea, to going home versus going into a long-term care facility. And for the time being, then it relies on pretty complex observational and analytic methods to try and figure out, well, who were the people who would have otherwise gone into a long-term care facility but didn't? And what did that look like? And I think that is, the billion-dollar question, given that this decision is chewing up 14% of national health expenditure. And so, to summarize, I'm still an early career investigator. I'm trying to build together this body of work and also intervene to change how people make this decision. I'd like to give acknowledgements to my primary mentor, Ken Lee, for inviting me, the statisticians who helped me with my analyses, Irina and John, the NIA and the NIH for funding this work in part, and then also my patients who have obviously taught me a lot about this journey. I wouldn't know about it if I hadn't had so many people share with me what it's like going through this. So I titled this talk, Building the Evidence to Inform Long-Term Care Placement. I know the term placement is a little bit controversial sometimes in our circles, but hopefully from the qualitative data, I demonstrated that that is what the experience is like. I hope it's not placement in the future. I hope it's a choice, but we'll see what we can do to maybe make this decision process a little bit more informed. With that, I open it to questions.
Thank you so much for such a great talk. It's so thoughtful and such a relevant problem for so many of our patients and families. I think we have a couple questions. Jeff Linder has a question. Can you talk about the potential circularity of the care trajectories and the risk factors for being in a care trajectory?
Yeah, I wrote this up as a limitation in the manuscript so far, where we debated whether or not we would come up with some sort of adjusted analysis or try and control for attrition bias. And I said, I'm just going to present the data as is because I think people want to know what's normal. And I think that's what this analysis shows. I don't want to use adjustment or anything like that because I don't know if entry was due to the decline in function or whether or not the entry led to the decline in function. So I've been very delicate about this. There is potential circularity. The care trajectories, I think I can avoid if we only look at the trajectories prior to entry because data are prospectively collected. There's no way they would have known that they were going into a long-term care facility. So I think it's less circular there. If we basically consider the trajectory as a complex predictor and only include data prior to entry, I think we avoid circularity there. But I do think for the presentation of the data overall, this is why I pitch the data largely as explaining what's normal, not trying to say there's a causal effect. Because yeah, there are infantilization theories, for example, which would argue by putting someone in a long-term care facility, their function declines because now you're doing too much stuff for them. So very unsettled. I'm aware of those possibilities. And still, I think the data are interesting and hopefully valuable and important, but we'll find out what reviewers think.
What other questions do we have? Oh, here's from Lee. You can see in the chat there, Kenny.
Yeah, good. Hey, Lee. Good question. I don't know. The question is, will people use the decision aid to confirm their decision, since there's strong feelings about it at baseline, to decrease their guilt or to make a prospective decision? Again, I have the first qualitative person to interview. I'm trying to interview people who have recently gone into long-term care to understand their decision process and the role of information in that process. And I'm not sure. That's really one of the goals of the qual study. The quant actually informs my qual recruitment process, where because now I have median and average data, I'm trying to recruit people from all sides of the spectrum. So people who got a lot of help, people who got very little help, to basically make sure I've rounded out these stories. I don't know how it will be used. I think that will require implementing the decision aid. And again, here, hopefully I don't get destroyed, because we did do all of this ACP work as an example, even though we found that that did not change the intensity of care that people get at end of life, but still we funded this work. And so I am going to try and perturb the system at some point, and hopefully see the extent to which it changes things. I don't know. Yeah, I don't know, but I do think,
that's a great answer, Kenny, because I'm trying to figure it out too, because it's like people have such deep-seated love for staying at home versus sending them to the nursing home. And that's the thing where, how is a decision aid that's technical going to support them? And that's what I think is fascinating with your work.
Yeah.
One other question I had too is, how do you think COVID's going to affect this? Because the NHATS data, I think, is what, every 2 years, or how many blocks?
Every 1 year.
Every 1 year. Yeah.
I can study that. So part of me is trying to build out the framework for it, right? So do we now move people from the gradual decline to the high needs group in terms of like what life is like before they enter? I don't know. I actually think, and what I'm seeing at the skilled nursing facility / continuing care retirement community that I work in, is that people held off a little bit, maybe like 1 year, but now there's a flood of demand for assisted living and nursing homes all over again. And part of me is like, that's not a surprise at all to me. The idea of aging in place is very old. People have not wanted to go to care facilities for as long as at least I've been in practice. So why would COVID change that? It changes the balance around it a little bit, but it was always a last resort decision. So it's just still a last resort decision. So yeah.
No, thanks. Awesome talk, Kenny.
I appreciate these comments. Babette Sanders, yes, that's surprised that no one suggested SNP for rehab. So there's actually, so in that original 2006 paper, what he illustrated, what Dr. Kane illustrated, was that based on your specialty, it changes your recommendation entirely of where people belong in the system. So I wasn't sure how much homogeneity we were going to get with regards to the response versus heterogeneity. I was expecting heterogeneity, but also in that scenario, he asked people to keep varying small degrees. And I can't go and do that because that would take the whole talk. We could like have varied what happens if now the husband has passed away and she's recently widowed. Does that significantly change your decision or not? So yeah. Yeah.
Any other questions?
But I would just comment. So I did inpatient ward, general medical wards, kind of over New Year. And so just to pick up on Babette's talk and your, trio of Spider-Men pointing at one another, that, the conversation we have on rounds as well, physical therapy said, is recommending this. And we probably, I wouldn't say we take it as gospel, but, that's sort of our default starting place. And it often is SNF with rehab. And it does feel kind of like a default starting place when we're trying to make, multiple decisions for multiple patients on morning rounds. I'm not quite sure what the answer is to sort of make it more holistic. Our residents definitely have interdisciplinary rounds with social work and nursing to kind of go over disposition as well, but yeah, I don't know if you have thoughts about that, Kenneth.
I have lots of thoughts about that. In that there's another project that I worked on. I put in a bunch of slides. So this was it's interesting because in Toronto, geriatricians work primarily in the hospital, and the number one reason for consultation is disposition planning.
Yeah.
And the reason why is because we control the whole system. We control home care contracts, we control long-term care, we control the hospitals. It's a single payer for the whole thing.
Yeah.
And the question immediately becomes, well, what's the best place for this person such that you won't have a readmission? And we're very aligned with regards to like making sure that's done right, because if you fill your nursing homes, you can't clear your hospitals. And so that's what we do. I came to the US and it was very interesting to sort of change systems and figure out what is the same and what is the different. Obviously, the clinical cases are exactly the same: falls, fractures, cognitive impairment. And one of the projects that I worked on as a QI fellow through the VAX program was really trying to explicitly explain my framework for thinking through how do you handle a complicated discharge. And this was the model that I came up with, that a simple discharge, they're medically stable and they leave. And discharges get complicated when you take for granted the discharge destination, who's paying for it, and who the decision maker is. And post-acute SNF lives as this very, very confusing world, which is a limited funding source. And as someone who now works in post-acute SNF, I know I get dumped a lot of people where this has not really been figured out. And people haven't really properly been assessed for rehab ability, and because of pressures to have people leave earlier, sometimes the hospital team hasn't had time to figure all this out. So I don't think the process is necessarily better, but if you're looking for the framework of like, how would you actually think through this whole thing? This is what I use when I try to explain or teach residents about this concept about transitions, is that you have to think through where are they going? Who is the person making the decision? And then who's paying for it? And really, what is the long-term plan? And this was piloted in the VA, which has a little bit more vertical integration and thus right incentive structure to do this right. But these are the areas or the services that you need to consult to try and answer that question as well. So it's a model for interdisciplinary care and also a model for a structured approach towards a complex discharge.
Great, thank you.
Yeah, you're welcome.
Hi. This is a really interesting talk. I guess I have a little bit of a different question. I'm just curious about your thoughts on when you were talking at the beginning. I really was thinking about just like there's just a shortage of affordable housing for people, especially older people who may are looking for a transition, or their family's looking for a transition for them, and it may not be like going to this really fancy assisted living is just not affordable, and there really aren't other options. And I'm just curious, like, how you've thought about that, or if you have thought about that at all, and like, what could fill that space.
I'm pretty sure any decision aid will need local information about pricing and availability. And it's interesting to me because I think the primary difference between Canada and the US is that in the US, it is mostly a private decision where you end up. And thus it is both a financial and a health decision. My concern is that underneath all of this is a question about, especially from caregivers, not necessarily from patients, safety. And I can't help but think that as a doctor, isn't that, or even as a healthcare professional, isn't that our wheelhouse? We don't have to tell them where they ought to go, but we should know how important it is for safety. Because people are asking, is it safe? And I'm like, I have no idea. So the cost is one thing, and I would flip it also in that, when I get upset, in the Canadian system, one thing that happened was we ran out of money to provide as much home care as we could before. We cut daily hours available from 3 hours down to 2 hours a day. And I just remember thinking, like, what is the healthcare cost of this? And in the US, this now pans out in the version of the question that you asked. If you can't afford the assisted living facility, or you can't afford that number of hours of care, what is the implication? Or framed differently to a caregiver, I'm thinking about quitting my job to care for my loved one because I want them to stay at home longer. Does that even make a difference? Or is invariably what happens a fall, a fracture, and then you can't do it anymore? And so once again, I think there's a lot of different ways to frame it. That's why I think it's taken so long to come up with the conceptual model for it, that the driving features at the end of it are how functionally able is this person? Where are you getting the supports from, if from many different places? And that's why in the analysis that I showed, I boiled it down into caregiving hours. I know not all hours of caregiving are equal because you can train caregivers differently. And some people are willing to do some tasks, but not other tasks. But at day's end, there's at least some immutability to a caregiving hour in terms of how much it costs and how long it takes. And so that was the rationale behind that decision. But I'm aware that it's going to require a blend of quant and qual methods to try and answer this. But yeah, it's a good question. So that's what we work on at our Pepper Center. It's sort of the bridge. Our Pepper Center, the theme is predictors, outcomes, and amelioration of late life disability. Ken leads it. He's my primary mentor. The things that we work on are basically, how do you measure the aging process? How do you analyze it and come up with meaningful conclusions? How does that help medical decision making, and how do you apply it to vulnerable populations? So you can see how sort of like the Pepper Center that I grew up in has informed, you know, my work. But it's hard.
Well, thank you again. Any last questions? We're approaching the 1 o'clock hour, but any last questions for Dr. Lam? I don't see any hands raised. Well, thank you again for your time. We really appreciate it. It was a great talk.
Thank you so much. It's fun. I hope you like that Marvel shout out too with the Spider-Man lead. I was like,
Thanks,
yeah.
Kenny.
Okay, well, thank you so much, and feel free to reach out if you guys have other questions. I just hope to, again, channel the energy of everybody interested in this space as best as possible.
Thanks, Ken.
Thanks for joining, everyone. We'll see you next month.